This lecture is being brought to you in part by the generous gifts of these sponsors.
Thank you for that kind introduction. I'd like to thank IHMC and Dr. Ken Ford for inviting me to be with you tonight. It's an honor to be part of this lecture series that I've been hearing about off and on for the last couple of years. So it's a pleasure to be here. I'm a native Floridian, originally from Tampa, been in Sarasota for 15 years and enjoy it quite a bit. So before we get into the lecture, we'll have just a little bit of initial interaction. So how many people know someone with a thyroid problem? Aha, okay, good. How many people know someone with a thyroid nodule? Very good. How many people know someone with thyroid cancer? Good, and so that's about right in terms of the percentages. So these are very common problems. And we talk about thyroid and weight and metabolism and things like that, and often people say, oh, you're a thyroid expert, you must deal with a lot of people who have weight issues. I said, no, that's a very small part of what we do. You know, a lot of these issues have significant heart effects, bone effects, can be malignancies, et cetera. So we're going to start diving into some of that. Just as a primer, though, let's talk a little bit about. There was a pointer up here, but that's okay. Oh, here it is. Perfect. So a little bit of a thyroid gland, just so we are oriented here. So this is a butterfly-shaped gland at the base of the neck. And typically, it's about 2 inches long on each side and about a ½ inch wide. Most of the time, you can't feel it. Often people come in and say, I've got this glandular thyroid problem, and they're not feeling the right glands. These are your salivary glands, maybe some lymph nodes, et cetera. So if you're thinking thyroid, think right above where the collarbones come together, and that's typically where your thyroid is. And normally, you can't feel it unless you have a thin neck, or sometimes you have a high-lying thyroid. So thyroxine is the hormone that thyroid makes, and that controls metabolism. So you're thinking that's weight. Well, when we think of metabolism in medical science, we're thinking about cellular function, a little bit of energy regulation, which is our way of saying weight management a little bit. So it affects the body temperature, heart function, nerve and brain function, muscle strength, GI motility, so it can, in terms of constipation, diarrhea, things like that, and importantly, fertility. So if your thyroid's not working, you're not working. So it's a very important gland. So if you have any symptoms that are non-specific, and that's the problem with thyroid symptoms, often people say, I must have a thyroid problem because I'm tired and I can't lose weight. Well, that probably describes most of us. And so the thyroid function testing, luckily, is fairly accurate. It's saying this is your thyroid, or no, it's not your thyroid, it's something else. But if you have some of those symptoms, it's worth asking your doctor to do a test. So what we're going to focus on tonight, though, is this question of a thyroid nodule. So this lady comes in with remember we know our thyroid's not up here. We've already oriented us to down here, and you can see a bulge on the right lower neck here, and she discovered it. So she's coming in and saying, mainly, is it cancer? Because when any one of us feels a lump, that's our first concern, is it cancer? I have two other clinical questions. Is it causing you symptoms? Any trouble swallowing? Any trouble with breathing? Any trouble with voice, tightness, pressure, choking? And is it impacting thyroid function? So those are my 3 questions. And actually, this question should be, as you'll learn in the next 45 minutes or so, not just is it cancer, but is it a cancer that needs to be treated? Or is this one of the little microcancers that up to 30% of us have that exist in the thyroid that just can be watched over time? So this is the main. So the question is it cancer? But the second question is, do I need to do something about it? So how do patients typically come to me? We looked at this a few years ago and presented it at a national meeting of the American Thyroid Association. And we looked at about almost 500 patients that came through our clinic and said, how are these discovered? So about 25% on physical exam by the healthcare professional. Patient detected 15% of the time. So 40% were someone felt it. But 60% it was an incidental finding. Now, a lot of the time, so what does that mean, incidental? Well, incidental means you were doing an X-ray or an imaging study for reasons other than suspecting a thyroid nodule, and we discovered this. Sometimes it's a little bit of misadventure. What I mean by that is patients come in with symptoms suggestive of thyroid. I'm fatigued, whatever it is. I'm cold. Let's do an ultrasound and see what your thyroid looks like. Well, that's not going to tell us thyroid function. The blood test tells us that, but still common practice to occasionally screen for symptoms with ultrasound and also for abnormal thyroid function tests, but these weren't looking for nodules. So CT scan, carotid Doppler, MRI, and PET scan make up a very common source for incidental nodule discovery. So why is this happening? And the question of, we had one question of, does it change the risk of malignancy? So the people who on average, about 5% to 7% are malignant, are cancerous. And the two greatest, first PET scan. Remember, PET scan is often used for cancer screening. So if a nodule shows up on PET scan, it's a higher risk. So 20% of those were cancer. Self-palpation, 9.3%. And carotid Doppler, 12%. So interesting look, but when patients come in, it's almost always for these incidental discoveries. So why can we see the thyroid so well during carotid Doppler? Well, this is an image showing the skin's up here, trachea is here, that's the windpipe. This bright Doppler signal, so Doppler measures shifts of sound, essentially moving sound. So the blood flow is intense here, and this is a thyroid nodule. So if a person is doing a Doppler ultrasound of your carotid artery and you have a thyroid nodule, he or she should note that because they're neighbors. So this is a very common relationship here. CT scan, also common. So this is a cross section. So you have the windpipe here, you got carotid artery here and here, and you have a thyroid nodule hiding here, easy to see. This is very easy to see. This big egg-shaped thing, this is this is your spine, your eyes would be looking that way. So this is your windpipe, food pipe back here. That's a thyroid nodule. Now sometimes people have these huge thyroid nodules that have been there for so long, they're not even aware of them. So they'll pick them up incidentally on a spine film, because maybe they have arm tingling, so they get a CT of the neck and spine, and you end up seeing a thyroid nodule. And I tell my patients, if I put your nodule in my neck right now, I would have symptoms, but they don't have symptoms because they've gotten used to it over time. Often, though, nodules this big do have symptoms. Just one last nodule in cross-section. So these are the apices of the lungs, so the tops of the lungs. This is the front of the chest here, and then the thyroid nodule here. So easy to see because we are doing a lot of medical imaging in the neighborhood of the thyroid, so that's how we pick these up. But the same clinical questions are what we think about. Is it a significant cancer? Does it cause symptoms? And does it affect thyroid function? So how common are these? We got a little hint of that just by the raise of hands in the beginning, but if we look at two different ways, and this is the late Ernie Mazzaferri, one of my mentors when I was at the University of Florida, back in the, when was that? 2000, 2002 time, or 2000, and he had looked at, back in 93, how common are nodules. And you'll see with ultrasound or autopsy, in other words, not necessarily nodules we can feel, the incidence of thyroid nodules increases with age. So at 50 or 60, almost half of people have thyroid nodules. And for palpation, in other words, I can feel it or the patient feels it, it ends up being about 4 to 5 to 6%. So most of these nodules are something that we can't necessarily feel, but if we ultrasound everybody, we'll kind of see a lot of nodules. That's why we don't recommend screening, because we'll find way too much, and we'll create a lot of anxiety, unnecessary costs, unnecessary procedures. So once you have a nodule, the question is, well, why do I have the nodule? Everyone says, well, how did I get this? What can I do to make it go away? And usually for an individual patient, I can't say, this is what you're doing in life that gave you the nodule, but I don't know, this is an androgynous looking person to me, but smoking, using the cell phone, and the quote is, how scary is that radioactivity from Japan? So these are the concerns that this person has. Meanwhile, you've got the central obesity. You've probably heard about insulin resistance if you've been to any talks here before. They're eating the supersized soda. They have a very Western lifestyle. So the person here does not have iodine deficiency. If you look worldwide, though, at what's the most common cause of nodular goiter or thyroid enlargement, it's going to be iodine deficiency. We don't typically have that in this country unless you're on specific diets. Autoimmune thyroid disease, meaning the immune system attacks the thyroid, pretty common. Up to 15 to 20% of women in North America have that, and that can sometimes cause nodularity. Family history of smoking has caused nodules, but actually smoking is not associated with thyroid cancer. ionizing radiation exposure, and that's from either therapeutic radiation. Remember the 1910 to 1960 range, we thought radiation was great for enlarged thymus or tonsils, even acne, so we used it unscrupulously, and often those patients develop nodules. And insulin resistance, that's that phenotype of central obesity there. So if you're then still asking, I have a nodule, what can I do about it? Well, if you're smoking, stop. If you're insulin resistant, decrease your sugar and carbohydrates, work on your weight. If you're diabetic, get your A1C down. You can't change your family history. You're probably not iodine deficient, but if you're worried about that, you can be screened for it. And you can easily be screened for autoimmune thyroid disease. So there's some things we can do to sort that out for you. So the first thing we do if a patient has a nodule is we check thyroid function. A small number, maybe 4 or 5% of these, will actually be autonomous. Autonomous means that the nodule will produce thyroid hormone independent of what the body needs. So usually the pituitary sends a signal called TSH, thyroid stimulating hormone, to the thyroid to govern and balance how much thyroid hormone is being produced. But if these nodules have a TSH receptor mutation, meaning the nodule doesn't pay attention to what the brain or the pituitary is saying, it becomes rogue. So it starts producing extra thyroid hormone independently. The nice thing about them is they're almost never cancer. The bad thing about them is they can cause, because of the overactive thyroid production, stealing of calcium from the bone, so osteoporosis and fractures, and heart rhythm problems. Most concerning would be atrial fibrillation with stroke. So these can be problematic and do need treatment, but they don't need biopsy. So the next thing we do is we look at the ultrasound. And this is what I do all day long and teach other people to do a couple times a year. But if you can't really, don't worry about trying to figure it out. But the idea is that there's multiple different patterns of how these look on ultrasound, and then we risk stratify based on the appearance. The reason we're doing that is because there are simply too many biopsies occurring. If you do all these ultrasounds that are being done in the States because of all these incidental findings, you're going to see this dramatic and unnecessary increase in the amount of fine needle aspirations. FNA is fine needle aspiration. What does that mean? That means I take a needle, smaller than a blood draw needle, and I put it in your neck and do the nodule a few times. Doesn't hurt that much, but these are happening 500,000 to 600,000 times a year in the US. And that's a lot. And that's too much, especially in the realm of now we're getting to know ultrasound better, but people are not using these, they're not recognizing this. They're not using the new guidelines yet, but we're starting to. So the guidelines said, let's try to decrease the number of unnecessary biopsies. So let's remind people that if you have a simple cyst, a fluid-filled spot on your thyroid, that's never cancer. Don't biopsy that. If you have these types of benign overgrowth patterns, don't biopsy those. But once you start getting more solid growth patterns or patterns with calcification or lymph node involvement, then on ultrasound, you're saying, oh, I have a problem here. I need to biopsy it. So ultrasound allows you to triage, and in my practice and other people's practice who do this on a regular basis, we can decrease the number of biopsies. So half the people who are referred for nodule possible biopsy may not even need a biopsy, which is great. So we're trying to decrease this trend upward in biopsies, but we still have a lot of work to do. So what does a biopsy look like? This is me putting a little needle in under ultrasound guidance, and this is the needle into the nodule, making sure we don't go to the carotid or the jugular. It's still a small needle, so we can get away with it, but we prefer not to. So this is what it looks like. So once we get that sample out, we look at it under the microscope, and we make sure that we've got a good sample, and then we ask the pathologist to tell us what's going on. So we used to only have basic categories of inadequate biopsy, benign, indeterminate, in other words, I can't quite tell, or cancer. And then we divided it into 6 categories in 2007, 2008 with the Bethesda system. So as you know in life, the more categories from which a person can choose, the more difference there is from the observer. So if you have 3 or 4 different observers and you have only 2 choices, they're going to be pretty concordant on saying yes or no. Once you start saying, I've got 5 choices where you can say, I grade this as whatever category, there's going to be differences in opinion. So you open up a little bit to not to more biopsy results that are not straightforward benign. Then my problem with this is the atypia. So what used to be this atypia of uncertain significance, which is supposed to have a 5 to 15% risk of cancer, a lot of good pathologists would have just called that benign and said, well, that's okay in the past. But now they've got this garbage pail potentially where if they're not sure about something, they can put it into atypia, and then they always add the comment, clinical correlation advised. In other words, now it's back on me. So I don't have a benign biopsy. I've got something that's atypical or indeterminate, meaning it's suspicious for a neoplasm. When we say neoplasm or tumor, that can be a benign or a malignant process. So tumor, neoplasm just means abnormal growth. So these are great because about 70%, 80%, 70% of biopsies will come back benign. About 5% will come back straightforward malignant. And then you've got some that are suspicious for malignancy, which is high risk. But then you still have these in the middle that we don't know quite what to do with. So this is a dilemma that we face. And you probably, if you know someone who's had a thyroid nodule biopsy, you probably have heard this concept of we don't quite know what to do. It's indeterminate or inconclusive. So if we look at the number of biopsies being done, this may be 100,000 cases per year of nodules that are inconclusive. And they might have a 20 to 25% risk of cancer. And historically, we sent them all for surgery because we didn't know what else to do. So that means if you have a 25 to 30% risk of cancer, you've got 2/3 of patients going for diagnostic surgery that end up with a benign nodule. And you probably know someone who had that happen. I mean, some people probably know of someone who had that happen. So luckily, in the last 6 years, we have some genetic or genomic testing available to take these people with indeterminate biopsies, do additional testing, and then figure out the risk stratification. So beyond basically looking under the microscope, the risk stratification can be done with genetics, which is pretty cool, but it's very early in its utility. So there's a lot of pitfalls. So before we talk about the genetics, it's important just to talk about thyroid cancer subtypes in general. So I'm going to talk through this because it's kind of a small slide to see, but when we talk about thyroid cancer, the most common is differentiated thyroid cancer. Differentiated in biology means that the cancer cells are of the same origin and have similar appearance and function to the normal cell of that organ or gland. So these differentiated thyroid cancers have the ability, just like the thyroid does, to take up iodine and to make thyroid protein, like thyroglobulin. So we exploit that ability of these differentiated thyroid cancers when we do treating and testing for these patients. So most of these are papillary thyroid cancers. And when we talk about microcancers, or these little less than 1 centimeter cancers in the thyroid, the vast majority of these are papillary, and they very seldom cause significant problems unless they've spread to lymph nodes or distant. So we have this on one side, this 80 to 85% of all cancers are papillary. The next is follicular. So follicular is slightly more aggressive. And then we also have a Herthel that's a subtype of that. So they tend to spread a little bit more than papillaries. We have medullaries that are not from the usual thyroid follicular cells. They're from a different cell. They have a worse prognosis. They tend to be more genetic with mutations. And pretty much the rest of the talk will not focus on this rare type of thyroid cancer. And then we have this anaplastic. Anaplastic, by the name alone, makes you think this is a bad player. This is completely unrecognizable. It's not differentiated. It's not organized. Luckily, only about 1 in 100 thyroid cancers, and usually about a 6-month survival. So you have one gland that, at one end of the spectrum, will harbor one of the best patient outcomes we see in cancer for humans, is papillary thyroid cancer. These people do very well. Some of them may not even need treatment. Unfortunately, it's been termed the good cancer, which is a terrible thing to tell someone with cancer, that you have a good cancer. There's no such thing. I want someone else to have my good cancer. So you don't want that. But at the same time, the same gland will host one of the worst prognosis we get in human oncology, which is the anaplastic thyroid cancer. Virtually untreatable, almost a death sentence. So luckily, we don't see that many of them. And there are some new trials and protocols that hopefully will improve this outcome. But most of our talk is going to really focus on this differentiated cancer. Busy slide, but just a simple reminder. The global view on this slide says, if I've got one of these follicular cells and it's going to become cancer, usually there's some mutation that occurs to drive that process. So we can divide that into, for people who have genetic backgrounds, RAS mutations, which are more of your follicular, or BRAF-like, which are more papillary. And that's the first step. So that helps us maybe in diagnosis, doesn't really help us in risk stratifying behavior that much. But if you get additional mutations that occur, like TERT, and you add them to BRAF or RAS, you're going to start seeing these anaplastic and poorly differentiated cancers emerge. So you get these driver mutations, and this is, a lot of the oncology world now is looking at genetic status, and often the oncology notes I see, I'm not an oncologist, I'm a thyroid person, but I do thyroid oncology, is are there any actionable mutations? So if you have a tumor in this day and age, and they can test mutations that are associated with your tumor, they're going to see if there's a drug or a therapy that's designed to help your specific situation. So this information is becoming more and more important, not only for diagnosis, but for treatment. But going back to that question of an indeterminate biopsy, now we can send that same biopsy sample for testing like ThyroSeq, which is offered through the University of Pittsburgh Medical Center, and we can test gene fusions and gene mutations, fusion types, expression, and mainly look at these BRAF and RAS and RET and PPAR, and these are the things that now we're using to say, I had an indeterminate nodule, I was worried enough to do a biopsy, the pathologist wasn't sure about it, but now it's got one of these mutations. So now I'm worried because if it has a mutation, depending on the mutation, the risk of cancer is anywhere between 60 and 99%. So I'm not comfortable watching that. But if it doesn't have a mutation, and looking for a little more validation on this, but currently the data says it's similar to a benign biopsy. If we can't find a mutation, it's about 3 to 5% chance of cancer. So then you have to use clinical judgment and make sure that that matches the ultrasound appearance, the history, the risks, what the rest of the neck looks like, et cetera. But it gives me a lot of information to say I'm comfortable with what we call active surveillance. We used to call it watch and wait, but we'll call it active surveillance. We're doing something, we invite the patient to come back, we make sure things don't change. So now we can take these patients, all of whom were previously advised to have surgery, and take probably half of them out of that surgical pool and have a better diagnosis. So if we have benign nodules, which most of these nodules end up being benign, some of them, though, wear out their welcome. They can have overactivity, they can have compressive symptoms, etc. So we have a quick little checklist. If they are indeed hypothyroid, so if someone has autoimmune thyroid disease, meaning the immune system has attacked the thyroid, you might have heard the term Hashimoto's thyroiditis. That's the classic autoimmune thyroid disease. Sometimes you'll see nodule growth in that setting. So if those patients have low thyroid status, you give them thyroid hormone, often the nodule will shrink. That's the most common scenario. If they're iodine deficient, replace it. Sometimes you can use radioactive iodine, so taking advantage of that iodine uptake that the thyroid cell depends upon, because it depends upon iodine to make thyroid hormone, we can take advantage of that and give radioactive iodine and often shrink these nodules down. If it's cystic, we can put alcohol, inject alcohol into it. And then other thermal ablations like laser, HIFU, a high-frequency ultrasound, and radiofrequency ablation. So there's options that are non-surgical. But often patients will come assuming they need surgery because they have a thyroid nodule. And maybe that was old school, but hopefully we've already talked to the fact that we can get a pretty good clinical evaluation of the risk for cancer. And so if we have a concern for cancer, then that's a very good indication for surgery. If it's an over-functioning nodule, we can remove it or give radioactive iodine. If it's symptoms due to size, if it's over-functioning, it's a good indication for surgery, or compressive symptoms. And with a good surgeon, often that's the best choice, is just remove the offending problem. So now we'll move on to thyroid cancer. So thyroid cancer has become equally epidemic as our discussion of thyroid nodules. So in terms of one, it's the most common endocrine malignancy. So endocrine being our field of hormone-producing glands. Fastest increasing cancer. Now, don't confuse fastest increasing cancer with fastest growing cancer. Fastest increasing means the annual increase in the incidence, or per annual new cases, is increasing faster than any other cancer. It went from the 8th most common among women in 2005 to the 5th in 2013, likely to be the 3rd by 2019. And so 6% of cancers in women are thyroid cancer. So it's becoming more common. But we talked about incidence rate. So thyroid, fastest increasing in incidence. So 4.7% per year increase between 2004 and 2013. And how about death? Well, if we're discovering all these nodules and we're treating and we're just figuring out which ones have cancer and we're treating them, shouldn't the death rate be going down? It's not. It's actually trending upward, 0.5% per year, maybe 1%, and depending on what time frame you look at. So we're seeing an increase in incidence that's pretty tremendous and a slight increase in death. So we'll get back to that. But so you're thinking now, okay, we talked about why do I have a nodule, but could my nodule be cancer? So there's extrinsic and intrinsic factors. So we talked about ionizing radiation, both a risk for cancer and for nodules. And we've come full circle a little bit. We know iodine's good for the thyroid, but too much iodine in some studies have increased the risk of these small papillary thyroid cancers. So don't overdo it on iodine, but you want to make sure you have enough iodine. So 150 micrograms, 250 micrograms, that's fine. Some people take 12 grams, or 12 milligrams, which is 1,000 times more than you need, or 100 times more than you need. Westernized lifestyle, so same things that causing these nodules in terms of insulin resistance could be increasing cancer. Not enough data on environmental pollutants, but we know there's certain endocrine disruptors that change the thyroid hormone production, so maybe that increases the risk of cancer. And there's just too many chemicals to really sort out. So tough to figure out this environmental part from a standpoint of toxin. So intrinsic, so people who have a slight elevation in TSH, meaning they're a little bit hypothyroid and they have a single nodule, that's, for some reason, that's an increased risk for thyroid cancer. Autoimmune, a little bit, family history of thyroid cancer, and this obesity and insulin resistance. So most patients have one of these. Sometimes it's modifiable, sometimes it's not. When we talk about radiation exposure, we already mentioned that the use of therapeutic radiation for tonsils and thymus and acne went away probably in the 1960s. But remember the Nevada test site for nuclear testing in the 1950s with a lot of fallout of I-131 in the US. So a lot of exposure to radiation during that time. But if you look at the carefully done studies to say, well, we know there's some rearrangements genetically that are associated with radiation-induced cancer. So let's look at our tumor banks and test the tumors and see if that's increasing. That's actually beginning to trend downward. So our current upward trend in thyroid cancer incidence is not due to this radiation. I think we've probably seen the bulk of that. But we're actually seeing other mutations like BRAF and RAS increase, and they're not associated, that we think, with radiation exposure. So something else is happening. So how well do people do? We've kind of hinted at this a little bit, but let's assign some numbers to it. So if we have 64,000 new cases last year, and it's 3.8% of all cancer cases, so not, there's still a lot of other cancers people get. About 2,000 people will have a disease-specific death, meaning their death is associated directly with their thyroid cancer, but cause of all cancer deaths still only 0.3%. But 5-year survival is still 98.1%. So very good survival for thyroid cancer, which is why it's been called the good cancer, I think, it's a very problematic term. So who gets this? Usually it's going to be women 3-to-1 over men, and the typical age will be right in that 40s to 50s range. That's the median age of diagnosis is 51. People often ask, well, what stage am I? So the staging system for cancer in general is predicting the probability of death due to disease, which in thyroid cancer we see so few deaths due to disease that staging in that way doesn't really apply in most patients. And so we use, uniquely for thyroid cancer, age. And this year, they've changed the age. So it used to be that 45 and younger, the maximum stage out of 4, you could only be 2. And that's only if you had a distant metastasis. Now they said, these people do so well, even with meds, let's make that 55. So now if you're a 54-year-old person with a metastasis, you're only a stage 2. If you have lymph nodes, you're stage 1. So the staging has shifted, but it reminds us that most of these people survive and do well. We're more interested in the risk of recurrence because that's what happens on a regular basis, that we have to retreat to prevent death. It's not really the risk of death is important, and we have to recognize those patients who are at risk and treat them more aggressively, but most of our concern is recurrence. So we use slightly different staging systems that are beyond the scope of the talk. We talked about the gender difference, and that's true across all races. Pretty much holds true that 3 to 4 to 1 ratio, 3-4 to 1 between female and male. Maybe, why do women get them more than men? Thyroid has estrogen receptors. Obviously, women have more estrogen than men in most cases, so there's potential for more thyroid nodules, more thyroid disease, and potentially thyroid cancer. So just to remember, out of 100 people, 98.1% are still alive at 5 years, but let's drill down a little more. So who are those? And how do people present? Most people, if you look at this pie chart, and the big part of the dark pie chart is about 2/3 have localized disease. What does that mean? That means the thyroid cancer is pretty much confined to the thyroid. That's 2/3 of people. And if you have localized disease, you have a 99.9% 5-year survival. You're going to do great. Even if you've got some regional lymph nodes, which is about 25% of people, 97.8%. So often people think it's spread to my lymph nodes, the horse is out of the barn, here we go, but they still do very well with appropriate surgical treatment. If you present, meaning at the time of diagnosis, you come with a metastasis, not as good of a prognosis. At 5 years, 55% survival. So these are the ones that luckily are rare, about 4% of people, that we have to get on top of quickly, and hopefully with newer treatments, we'll be able to prolong survival. So does the data you're telling me apply to me in Florida? Well, sure it does. Except for Florida has one thing that is outpacing even thyroid. So thyroid's increasing at 1.9% per year between 2009 and 2013. Melanoma of the skin, 4.7%. Maybe there's just more dermatologists, maybe it's sun exposure. I don't know, but melanoma outpaces. So we're not, but other states, thyroid is, my friend from Utah was showing similar data. We were talking about state-specific, and melanoma was second for him. Thyroid was the fastest growing for Utah. So if you're looking at this, you're saying these people do pretty well overall. We're seeing an increase in incidence, but mortality is roughly flat, maybe a little bit higher. So surely you're just detecting small cancers that don't mean much. And sure enough, as we first looked at this phenomenon of explosion of thyroid cancer over a 20-year period, most of that increase, that spike from when we started doing arguably too much ultrasound, is in that 1 millimeter to 10 millimeters, up to 1 centimeter group. And then the second, of course, is the 1.1 to 2. And often people focused on this saying, this is just a detection bias because we're overdiagnosing based on incidental finding, and now we're using too many ultrasounds, too many biopsies. People kept forgetting to look at this one. More than 4 centimeters is creeping up. And there was an article that was published last week in JAMA that looked at 1974 to 2013 data and said that the advanced papillary thyroid cancers are going up about 3% per year. So it's not just detection. There's a real phenomenon going on, and there's something either environmentally or otherwise where we're seeing clinically significant cancers increase, and we're seeing an increase of about 1% per year in that longer study in mortality. So earlier detection is not changing mortality, and incidental detection doesn't tell the whole story. So if we look at survival rates by tumor size, so the reason we use size to decide what to biopsy is not because bigger nodules are more likely cancer, it's because bigger cancers are more likely to cause problems. So I don't want to miss a 3 centimeter thyroid cancer by not biopsying it. So I biopsy most everything above 2 centimeters that's solid. The reason is because once you get above 2 centimeters, your recurrence, your relative survival starts going down. At 4 centimeters, it's not looking, it's 88%, which looks okay, but this is, you have to remember your scale, it's between 80 and 100, but you can certainly see some separation between these curves based on size. Secondly, recurrence, which is the more common problem, is similarly bigger recurrence with bigger nodules and bigger cancers. So tumor size is important in terms of predicting outcomes. So there's this detection bias was really brought out with the South Korean experience. So they thought it would be a good idea, a value-added service, to look at women's clinics where they were coming in for breast health, mammogram, ultrasound, and say, let's just do a thyroid ultrasound on everybody coming through. And they had guidelines that were published in 2011 that said, biopsy anything you could possibly put a needle in, even if it's 4 millimeters, because clearly there's significant disease here that we need to eradicate. So they got very technically good at biopsying 4 millimeter papillary thyroid cancers, and they started screening in 1999, and look at this, boom, shot up. And in their population, mortality really didn't change at all. See, they had this huge issue. It was so big that even the best endocrine journal, the New York Times, picked this up in 2014 after it was published in New England Journal of Medicine. There was this big article about this explosion because of overdiagnosis. So looking at this in a different way in last fall, they said what happened, the expected versus observed thyroid cancer rates. And this is kind of tough to see, but most of you can see there's more color here and less color in these other countries. So in South Korea, by age 50, the incidence was 120 per 100,000, where they expected maybe 10, 15, something like that. So they were discovering all these cancers that were completely unexpected, probably clinically insignificant, and that was happening in areas that used more imaging. The United States, Italy, somewhat France, but not so much in Australia, and which is this one? Can't even read. The Nordic countries. So if you look, you will find, but we recognize that if 30% in some autopsy studies of patients who died from other reasons had little tiny microcancers, sure enough, you'll find them. So then the next question is, well, how does this relate? If I have a thyroid cancer, I'm not likely going to die from it. Let's put this in perspective. If you have 2,000 deaths per year, the lifetime risk of dying from thyroid cancer is about 1 in 1,667. So the more common causes of death, of course, are going to be heart attack, cancer, stroke, etc. So you have all of these things you're much more likely to die from. And in some cases, you might be more likely to die of a car accident going to your thyroid nodule workup than you are from your thyroid cancer. So, all right. Depends where you live. Okay. The other thing that was interesting is the socioeconomic impact. We know that cancer in general doubles the risk of bankruptcy, and thyroid cancer carries one of the highest risks at 3.5%. So the highest rate of bankruptcy, 3.5 times, fold. So average doubles, now we're 3.5 fold, and most of the people who file bankruptcy, which is probably not most of your patients, but again, relatively, it's happening in the first year. And this is for a lot of, probably the cost. These are young patients. They may or may not be well insured. It's often not a Medicare recipient, so their insurance is variable. They might have high deductibles. A surgery alone is going to be $10,000 to $15,000, depending on your hospital. Then if you get radioactive iodine, you get iodine scans, you get other x-rays, you get all this blood work. It's expensive, so that happens. Something we don't think about. So when we approach these cancers, I have to think about the ends of the spectrum. I can think about my little 9 millimeter cancer that I found incidentally on CT scan that doesn't have any other involvement, and maybe that person's going to do well, maybe if I just watch them. And this is in stark contrast to the patient who presents with neurologic symptoms because they've got spinal cord compression due to vertebral metastasis from thyroid cancers. That does happen. So these are completely different cancers in patients, and we have to treat them differently. So we have to know when to do less for these people with small cancers, and when to do more for these people who have thyroid cancer that a lot of even oncologists aren't used to seeing metastatic thyroid cancer, and what do we do for them? So we have to kind of leverage what we know about the biology and the genetics of this and figure out who to watch and who to be aggressive with. So we've complicated this in the current 2015 American Thyroid Association guidelines. So this is so complicated, I have to have this printed out on my desk to look and say, where does this patient fall? Because each individual patient now gets assigned a risk of structural disease recurrence. I mean, not so much risk of death, because we know that's usually with the distant mets. So I'm thinking, who's going to recur? How aggressive do I have to be with treatment to prevent that recurrence? So I have low, medium, high. So the good, the bad, and the ugly. So that's even how the authors of this were kind of thinking about it. Say, well, we know what low risk looks like. These are ones that are small cancers with no lymph node involvement, with no genetic mutations that are high risk, et cetera. We know what bad looks like. These are large tumors that are invading into the blood vessels, invading into the local muscle, have distant mets. So whatever is not clearly good or clearly bad, we can put in the middle, and we can call that intermediate. So, but there's this whole spectrum. It used to, in 2009, have about 40% of the possible categories. Now we've got all these other categories. So we're individualizing, which is great as a patient, because now you're getting customized care where you're getting probably less treatment than you would have 10 years ago if you came with the same thyroid cancer. So this is very good news. Just make sure your doctor's using it. So the other thing that's interesting, and this is a very busy slide, but if you take out, remember 85% of thyroid cancers are papillary, and a certain section of those papillaries we've always known do very well. They're follicular variant encapsulated without invasion. So about a year ago, well, exactly a year ago this month, again, New York Times, after the JAMA Oncology came out with this paper that said, or New England, JAMA Oncology said, maybe these cancers that we've always known do very well. So these are cancers that are encapsulated. Encapsulated means they're not invasive. The outcome over time is a less than 1% chance of a problem. Maybe we can really look and define a group of patients who have a tumor but not a cancer. So we don't have to use that cancer word psychologically, financially, et cetera, for these patients. And that's not a small amount. That's 17% of the 84%. So that's a fairly large number of patients with thyroid cancer who now moving forward, so we don't go back in time and relook at them and reclassify them, but moving forward, a good pathologist can say, this is something called a NIFT-P, or a nifty-P, as Ken Ford likes to call it. So NIFT-P. So what is that? That's a non-invasive, remember invasion is bad, so non-invasion, follicular thyroid neoplasm. Neoplasm just means growth that's not normal but not necessarily cancer, with papillary-like features. In other words, the biopsy maybe was atypical. There's some features that look like it could be papillary thyroid cancer, but not completely. So these are now completely encapsulated. They don't have any other high-risk pathology features, no aggressive histology. Usually they're the RAS mutations and not BRAF mutations. And so this is something that needs to be removed. Maybe it's not benign, it's a tumor maybe of uncertain behavior, because some of these potentially, if left alone, could progress into an invasive tumor, could metastasize, but we're not going to call them cancers. So surgery is still indicated. So we go back to that discussion of molecular testing, and if you have a patient who has one of these RAS mutations, which is the most common thing we see for follicular thyroid neoplasms, they're going to usually have RAS mutations, that tells me that needs to come out. But if it comes out and it's one of these nifty Ps, it's not cancer, but it had to be removed. Surgery was still indicated because we don't know long-term, is that a precancerous that could be a problem in the future? But that generated a lot of phone calls to the office, people saying, is that what I had? Can I say I don't have cancer anymore? And that creates this ethical problem of you go back. The pathologists don't want to go back and look at all these slides and recut them and try to figure it out. So this is now a discussion of, well, back in 2000, we did the best we can in diagnosing your cancer as a minimally invasive cancer. You've done great. Now we're calling those patients not cancer, but we're still treating you the same way, which is you're cured, you've done great. So same patient outcome, but now as we do this prospectively, probably these patients who are properly labeled will have less surgery. They just have a lobectomy. They won't have a total removal of their thyroid. They won't get radioactive iodine, and their follow-up will be less intense. So just like we had some of the features, clinical features, the neat thing is the molecular features also can be dividing into high, low, and medium risk in terms of what features you have. So as we're getting better information about the genetics, we can predict what to do. So the most important part of the treatment of thyroid cancer is surgery, or the decision not to do surgery for the microcancers. But if you pick surgery, and if you have someone that needs surgery, you have had to divide these patients up into low risk and intermediate and high risk. So low risk, now less than 4 centimeters. So the clinicians in the audience are saying, good Lord, you're going to take out just part of the thyroid for a 3 centimeter cancer? My gosh, that's unheard of. We used to take out the whole thyroid for anything above 1 centimeter, but now between 1 and 4, we can do a lobectomy and just remove part of the thyroid. But if they're intermediate and high risk, total thyroidectomy. Critically important is going to be look at the lymph nodes prior to surgery, because if you have 20 some odd % of patients who have clinically involved lymph nodes, you want to know about that. So you do careful ultrasound, maybe with CT scan before surgery to make sure you're not missing lymph nodes. So very important. And the nice thing about thyroid cancer, it's almost, with the exception of anaplastic thyroid cancer, it's almost never an emergency. So if you're told you have thyroid cancer or a thyroid nodule that needs surgery, you have time to take a step back, get a second opinion, get good preoperative imaging, decide on the extent of surgery, or decide if surgery is needed. You have time to do that. I know it's very stressful when someone's told you may have cancer, you have cancer, I want my surgery yesterday. With most thyroid cancers, you have weeks, months to figure it out. You don't want to wait too long, but you have time to get that opinion to get this right. So just a reiteration, in 2009, initial surgery for more than 1 centimeter was a total thyroid removal, less than 1 centimeter lobectomy. 2015, 1 to 4 centimeters without high-risk features can be total or lobectomy. And furthermore, they'll say for ones less than 1 centimeter, perhaps we can watch those over time. So we have shifted quite a bit, which makes some people uncomfortable. If you're looking at surgery, though, very important to make sure you deal with or work with a surgeon with a high volume. High volume means you want at least 20, 25 cases per year. Your risk then goes down to 2%. If you've done the math, 70, 85% of surgeries are done by people who do 5 or less in this country, meaning the person had a thyroid nodule, they had a great experience with their gallbladder removal with the general surgeon, so they go back and they say, hey, can you take this out? It's a thyroid nodule. They say, sure, I did one of those last year, I can do one this year. Unfortunately, that's what happens. People don't know. People aren't usually directed towards centers where you have high volume surgeons that can really decrease this risk. So after thyroid removal, especially if we've removed the whole thyroid, we have to give thyroid hormone. So we have to give a hormone that replicates the body's need, or meets the body's needs for thyroid function. So we give thyroxine. And remember, TSH is thyroid stimulating hormone. So if you've got any cancer that might be hiding, you don't want to stimulate it. So you want that TSH to be low. So if I give more thyroid medication, I can suppress or drive down the TSH. We know that patients with thyroid cancer who have a high TSH don't do as well, so we want to keep that low. And depending on the risk of recurrence and metastasis and death, it depends on how low we keep it. So we used to make a lot of patients completely undetectable with TSHs, which causes atrial fibrillation, which is a heart rhythm problem that could lead to stroke or bone loss. Now we have to weigh out the risk of tolerating too much medication and the risk of the cancer itself and individualize that therapy better. So this is the first systemic therapy for thyroid cancer, is suppress that TSH. The second systemic therapy for thyroid cancer is radioactive iodine. That's the original molecular targeted therapy. This is a 1949 Life. Remember Life magazine? Yeah, so Life magazine, another good medical journal, said radioactive iodine halts one type of cancer. This guy had a very weird presentation. He had metastatic follicular thyroid cancer with autonomy, meaning his metastases were producing thyroid hormone. So he was wasting away. And with 4 doses of radioactive iodine, he was cured and doing well. So that was the first highlighted molecular targeted therapy with radioactive iodine. Unfortunately, I was talking to someone who knew about this case last week and said, what happened to this guy? Well, apparently he died of leukemia about 10 years later. So radiation is good and bad, and they probably didn't, you are using doses that were much bigger, but he was probably going to die sooner of his thyroid cancer, so he got some time. So how does this work? Radioactive iodine. So this is a scan, it's kind of primitive, but let's look at the head, the thyroid area, and then lungs. We don't want to see uptake in the lungs. That means it's spread to the lungs. But if you have metastasis, usually at the first line of radioactive iodine, you've got about a 2/3 chance of taking up iodine, because most of those still have that quality that we exploit of differentiated thyroid cells, which differentiated will take up iodine, and then we use that to deliver radioactivity and knock it down. So the standard of care used to be total thyroid removal, then radioactive iodine at a relatively high dose of 100 millicuries. Almost 80%, 90% of my thyroid cancer patients up until about 8 years ago were getting that standard treatment because that was the standard of care. That was what the guidelines said. So now the therapeutic use of radioactive iodine has not only decreased, where probably only 20, probably 30% of my patients need radioactive iodine, because most of them are low risk and will do well without it. Because we've had well-controlled studies that said if you take people at low and low intermediate risk and you treat them with radioactive iodine or you don't, they do just as well. We thought they were doing well because we gave them the radioactive iodine, but they would have done as well anyway. It's just like the rooster who thinks the sun is coming out because he's doing his rooster thing, right? No. So radioactive iodine didn't cure them. The disease was just indolent to begin with. So, and we're using lower doses. So instead of 100, we're using 30. But then you have these mutations, back to this, BRAF mutated tumors tend to not take up I-131 as well, especially as they lose that nice differentiation. So over time, they don't accumulate well, and some of these patients get harder to treat. And with loss of I-131 uptake, enters increase in PET scan uptake. So there's an inverse relationship between a tumor's ability to take up I-131 and FDG, which is glucose metabolism, essentially. So the concept of cancer, and one concept of cancer is that part of the feeding of the cancer is anaerobic glucose metabolism, and we can clearly see this on PET scan. We have a good relationship between patients who don't take up or respond to radioactive iodine have higher PET activity, and people who have a worse prognosis have higher PET activity. So when I see thyroid cancer that looks like this, often you have multiple spots, occasionally one spot, I'm worried about that person. Their prognosis is worse. So not likely to take up I-131. So how do we treat those patients? I can't give them I-131. Usually they have multiple pulmonary mets, so I can't go in there and just remove it or radiate one little focal area. That's localized therapy. So what do? So I go back to biology. So I've got two cells that I'm thinking about. I'm thinking about a thyroid tumor cell, and I'm thinking about a vascular endothelial cell. Well, what does the blood vessel have to do with it? Well, the thyroid tumors have, just like other tumors, blood vessels upon which they depend for nutrition and growth. So if you can somehow decrease the angiogenesis or growth of new blood vessels, you can decrease the tumor. So these are usually VEGF, which is vascular endothelial growth factor receptor inhibitors. So we can inhibit there, and some others, fibroblast growth factor as well. So we want to somehow damage the blood supply, and then we want to somehow interrupt the factory. We've talked about RAS, BRAF, and then there's other signaling, and there's these receptors on the cell surface. So if we can somehow block some of this cascade of signaling and change that makes the tumor a tumor, we can maybe intervene. So luckily, in the last several years, there's been 2 that have been approved for differentiated, which is the main one we've been talking about. Remember, medullary was that rarer one that also has 2 approved, but we have 2 FDA-approved medications now for patients who previously had no options. There was this real large unmet need for patients who didn't respond to radioactive iodine, who had progressive disease and were at risk of dying from the disease or at least having significant symptoms. So then we take these agents, these medications, and this is listing not only the 2 that we listed here, sorafenib and lenvatinib, but looking at every currently identified site of action, and this is a cartoon from 2013, so there's even more of them, but that got way too complicated. And so we can knock out blood flow with several agents. We can knock out some other tumor growth, microenvironment supporting function as well, and we can block at some of these different mutations to decrease that cascade. This is different than cytotoxic chemotherapy. Often when people think of chemotherapy, they think, oh, that's the IV I got, and it wiped my system out, it made my white blood cell count low, I may lose my hair. And that's like if you had a village that you're trying to control, a tumor village, that's like blasting the village with a bomb. So what we're doing here is we're interrupting key infrastructure points of that village. You're interrupting water supply, so vascular, for example. You're interrupting heat. So you're slowing that village down from growing, so you slow progression down, but you're not wiping it out, which is why for both of these agents, we've seen a significant change in progression. So in one study of those 2 drugs, the more effective one, if patients were not on the drug, within 3 to 4 months on x-rays, their tumor was clearly getting bigger. That's called progression. We want to prevent progression because we think if we prevent progression, we can improve overall survival. And so if that placebo group was going at 3 to 4 months and seeing progression, the treatment group was 15 to 18 months. So we're getting a year plus a longer time before we saw progression. So we're actually making headway here with especially the lenvatinib. So we're seeing progress, but there's a lot of side effects. But what we're doing is we're altering the tumor microenvironment to slow it down. So very exciting with, I think, a lot better options in the pipeline with some of these other medications listed and combinations of medications. This is a very interesting time for those few patients. Less than 5% of our thyroid cancer patients will get to the point where we have to use these, but you have to recognize who they are and use them at the right time. So exciting time. Thyroid nodules are the most common problem in endocrinology. Some people would say, oh, diabetes is the most common. It's like, well, we maybe see more people with diabetes, or those who do diabetes, but thyroid nodules are the most common problem in endocrinology. Most are benign, and even if they're cancer, most have a great prognosis and can be managed with minimal procedures or even watched. And advanced thyroid cancer rates appear to be increasing, but we have new targeted treatments, better understanding, better training in endocrine-specific oncology now to hopefully decrease this over time and see some improvement in mortality rates and not the current trend that we're observing now. So I know that was a lot of information. Thank you so much for your attention. I can take questions. So I think, as was mentioned, we have a microphone. So I've got at least 2 questions here, if we can. 3, 4, yeah. So.
Doctor, thank you so much for your presentation. It's very exciting.
Thank you.
I wanted to ask you about the medications that you talked about of late. My husband died of cancer, but he had a different kind of cancer. And after his cancer was pretty much, I'm going to say allayed because of the medication, but after a while, the medications didn't work.
Right.
How does that work with regard to the people with thyroid cancer? Does it also, after a while, not work and then you have to do something different?
Tumors are smart, so they become resistant to treatment. And so sometimes stopping one treatment and starting another will help delay progression, but they have their own defense system sometimes. Sometimes it's limited by a patient's ability to tolerate a medication, the side effects, but sometimes it's just simply the tumor biology will change and adapt, just like we see with antibiotic resistance to certain bacterial infections. If we overuse antibiotics, then they don't work as well. So over time, the tumor adapts. So that's a good question, so thank you.
Coming. Question, you'd mentioned that the estrogen factor could be a reason why women get it at a higher percentage. I have a situation with a friend who had breast cancer that was an estrogen-fed breast cancer, so they're decreasing all the estrogen in her system. Right. But also in her family is the cancer, the thyroid cancer. So is there any positive side of decreasing the estrogen too?
Theoretically, usually we don't do estrogen deprivation for thyroid cancer. It's just more of an observation that there's estrogen receptors. In people who have family history that's strong for thyroid and breast cancer, there are certain genetic syndromes we think about, like Cowden syndrome, so our P10 mutations. So that might be something, with that history, to talk to a geneticist and see if additional testing is needed. But lowering estrogen status for that individual is not going to increase her risk, and it could potentially decrease risk for thyroid cancer. And that's a relatively high risk. So even though we don't recommend screening ultrasound, that's where maybe a thyroid ultrasound would be reasonable selectively in cases like that. I can repeat a question if you just.
You showed a bar chart showing increased incidence of these cancers, the red bars on the
Yes.
chart, and quite a few blue bars going the other way, showing what I interpreted to be decreased incidence of certain types of cancer. Can you talk about that?
Right, so the question was, looking at that SEER data on the incidence of cancer, we saw that thyroid cancer was increasing where other ones were decreasing. So if we're seeing decrease in lung cancer rates, we might attribute that to decreased smoking. Or if we're seeing decrease in colon cancer rates, maybe it's better screening. So some of the cancers that we screen for are probably getting better survival rates, like breast and colon, maybe prostate. So that survival is actually improving. And then from a new cancer diagnosis, things like smoking will decrease lung and maybe bladder cancer, things like that. So we luckily are seeing at the same time an increase, surprisingly in a few, we're seeing decreases in others. I'll do one more. Yes.
We have
Okay.
time for one more question.
Oh, one more question. Okay.
Can you speak to what your recommended course of treatment for someone with Hashimoto's and a nodule that the doctor is saying, let's just keep watching it? Is that kind of what you would suggest as well?
Oh gosh, I think any good answer in medicine, it depends. I mean, I can't answer that question without seeing the nodule, right? Remember we talked about ultrasound risk stratification, and we see commonly Hashimoto's with thyroid nodules and a slight increased risk of thyroid cancer. So you can't say you have a nodule with coexisting Hashimoto's, it's fine, watch it. You have to look at it. But often patients with Hashimoto's will have pseudonodules because there's so much inflammation. So you have to really carefully look with ultrasound and say, is it a nodule that's real or not? And if it's real, does it have any concerning features on ultrasound that warrants a biopsy? So you cannot have a blanket statement of nodule plus Hashimoto's means observation. I don't know if we have. Okay, we're good.